Welcome to this Beyond Zero e-learning module on multi-drug resistant TB. This particular module is going to be focusing on DRTB regimens and is part of the Wits RHI catch-up sessions. So let us look at the new MDR-TB regimens that are being rolled out in South Africa at the moment. Please note, I'm not going to be discussing pre-XDR or XDR regimens. So before we can start talking about regimens, we do have to look at our different classes of drugs. And the WHO has revised the classification of the DRTB drugs to also include some of the new drugs and to simplify it. And this is currently what we're using when we are putting regimens together for MDR and XDR-TB. Most people feel a bit overwhelmed when they look at this long list of medication, because it seems such a lot of the drugs are not that familiar to us. But if you look a little bit closer, you will find that actually a lot of these drugs we already know. Our first group there is our Fluoroquinolones. They're one of the key core parts of our regimen. And the most common one we're using is moxifloxacin, with levofloxacin used a little bit less so in children. Our injectables are very well known, not only for DRTB treatment, and the standard one that we use in our adult regimens is kanamycin. Streptomycin is no longer used or available. We'll sometimes use amikacin when we can. It's not quite as painful, the injection, so it's quite a nice choice for children. And capreomycin is something we use more in our XDR and third regimen, pre-XDR treatments. Our weird and wonderful drugs you'll find in Group C. This is what they call other core second-line agents. And the two I want you to remember for MDR-TB is specifically ethionamide, as well as clofazimine, one of the newer drugs in our MDR-TB regimen. The other drugs you will see more in the XDR and pre-XDR patients. And then our fourth group is our Group D, or add-on agents, and they're not core MDR-TB agents. And D1 there you will see is already familiar to us. This is all our good old-fashioned drug-sensitive TB drugs, pyrazinamide, ethambutol, and high-dose isoniazid. You'll notice rifampicin is the one drug that does not appear on these lists. Our new kids on the block is bedaquiline and delaminid. We'll introduce them a little bit more when we talk about their side effects and show you where they fit into the regimens. And then drugs we don't use very often, or those are the drugs we have to consider for pre-XDR and XDR drugs, such as PAS, imipenem, mepramin, and your good old-fashioned augmentin. So let us look at what MDR-TB regimens we now have available for patients who are diagnosed with MDR-TB at the present time. So I'm not going to cover some of the regimens we've been using in the past. We have standard regimens, which are all exactly the same, and then we have modified regimens that are modified. So standard regimen, our most famous one, the one that's getting all the press, is our standard short 9 to 12 month regimen. If there are patients who are not converting quickly enough during the standard short regimen, they might need an extended regimen, and you can see that's an 18 to 20 month regimen. Considerably longer than the standard short, and it is mainly based on how well they're responding to the short regimen. There's also a short bedaquiline regimen for patients who cannot tolerate the short regimen, the standard one, and that usually has to do with tolerance to kanamycin. So either developing ototoxicity or nephrotoxicity, and we therefore then replace the kanamycin with bedaquiline. There are also modified regimens. So these are regimens where you have patients on MDR-TB treatment, but they develop toxicity on certain ones, on some of the other drugs, or they have strange polyresistance patterns to some of the other drugs. And then you create, and what we've been doing pretty much up to now, you create an individualized extended regimen. And those regimens can be as long as 18 to 24 months. Let us look at the eligibility criteria of patients for starting the 9 to 12 month short MDR-TB regimen. Basically, all newly diagnosed RIF-resistant patients or MDR-TB patients with no previous exposure to second-line drugs automatically qualify for the short regimen. Even those patients who have had exposure, for example, MDR-TB patients who have failed, we will start them on the shorter regimen, but obviously we will prioritize to get additional information to establish any resistance to other second-line drugs. Your GeneXpert DRTB reflex test will be doing that for all your patients, trying to make sure that the patient may not have pre-XDR or XDR. Pregnant women do qualify for this short regimen, but they must be discussed with an expert, especially if they're in the first trimester of pregnancy, as there are great concerns about using the injectables in pregnant women. Let's look at what this regimen looks like. And it has an intensive phase, which is a minimum of 4 months, but can be as long as 6 months. And you'll see there it's got core 7 drugs. So now that list seems very, very long to you. If you look at the last 3 drugs, those 3 we know. It's good old-fashioned pyrazinamide, high-dose INH, that's what the little H stands for, and ethambutol. And those 3 drugs we're already very familiar with from our drug-sensitive TB days. The other 4 drugs has got our 2 core groups. Remember, we spoke about kanamycin, a very core part of our DRTB regimen, as well as moxifloxacin. And then we have these two drugs we're not so familiar with, which is clofazimine and ethionamide. And that makes up your regimen. So the regimen is not as strange as it seems, but there are 7 drugs that has to be taken. And then patients, once they've converted, smear converted, and we'll speak about that in a minute, they will then go on to continuation phase for another 5 months. And that's a standard 5 months. So that will include moxifloxacin, clofazimine, pyrazinamide, and ethambutol. So we're stopping our high-dose INH, we're obviously stopping our injectable, and we are stopping our ethionamide. And those 3 drugs are also probably some of our most toxic drugs in that regimen. So to try and get them off those toxic drugs as quickly as possible. If they convert and they're able to switch at 4 months to continuation phase, that will make it then a 9-month regimen. If they're not yet smear converted at 4 months and need another month or 2 of injectables up to 6 months, then you can see it will take them to an 11th month regimen. So let's see where we are at on our algorithm. So we started off diagnosing our patient as RIP resistant. We did some baseline investigations. And now we will start them on the standard short course of TB treatment. The idea is that we are doing the short course of TB treatment until it is proven that that's not the regimen for them to be on. And that is why that DRTB reflex test is so important. So although you've started the short course of TB treatment, you're still going to make a decision on that course once you get the result back of your DRTB reflex test, which will hopefully be back in as little as 7 to 14 days. If on that specific reflex test we find that they're INH sensitive, or we find that there's a single mutation, CAT-G or INHA, so not both the mutations, we can be happy that we're going to continue on the short course of TB treatment. But I want to show you that we will actually adjust the regimen depending on that mutation. So for example, if the patient has got a CAT-G only, we might decide to drop the high-dose INH completely, as it will not have much use. If the patient has got the INHA mutation only, we will drop the ethionamide. So the patient will continue on that regimen, but that will be actually a slightly simpler regimen. But if we have a patient that cannot use kanamycin, for example, we might have to use bedaquiline instead. And there's only very certain criteria where bedaquiline is an option. It's specifically for ototoxicity on kanamycin. That includes tinnitus, nephrotoxicity, which is not responding to adjusting the dosing, and the inability to tolerate the injections. And that would have to be severe complications or challenges with injections. The regimen looks exactly the same as the other standard short regimen, with 2 small changes. The one is we're replacing the kanamycin with bedaquiline. And secondly, we're changing the moxifloxacin to levofloxacin. The reason why we do that is that moxifloxacin increases the QT interval, and that's also an issue with both bedaquiline and clofazimine. So combining those 3 in a regimen just increases the risk too much. Levofloxacin can also do so, but in a much lesser extent, and is therefore our first choice for patients on bedaquiline. But But otherwise, the regimen is the same. We still have our ethambutol, our high-dose INH, and our pyrazinamide, so our known drugs. We've got our odd needle ones, clofazimine and ethionamide, and we've now added in bedaquiline. And then the continuation phase is exactly the same: moxifloxacin, clofazimine, pyrazinamide, and ethambutol. There's a couple of odd little things about this regimen to remember, and the most important of that is that although we are replacing the kanamycin with the bedaquiline, no matter at which point, so say for example they've already had 2 months of kanamycin and now there's ototoxicity and now you switch to bedaquiline, no matter what you do, the bedaquiline has to be given for 6 months minimum. So that means that sometimes you might even switch the patient to continuation phase, but you might be continuing the bedaquiline to finish that 6 months of bedaquiline. And then the other caveat, which I've already mentioned earlier, is that we're using levofloxacin instead of moxiflox. But some patients may not respond as well to that regimen as we would like. They might, for example, not smear convert by the end of the 5-6 months, or they might clinically be not improving. And they might need an extended regimen, but this is also note a standard regimen. So it's got standard drugs in it given at standard periods of time. In this case, the intensive phase, exactly the same drugs as the short phase, but we're now going to continue the intensive phase for 6 to 8 months, again waiting for smear conversion. And your continuation phase in scenarios like this is a full 12 months. So if a patient is taking a long time to convert on those initial 7 drugs, we're actually going to give them a much longer continuation phase, and that can lead to an 18 to 20 month regimen, but it's still standardly prescribed. But unfortunately, not all patients are going to be qualifying for the shorter regimens, and some patients are still going to need an individualized extended regimen. These are patients who have both the CAT-G as well as the INH-A mutations, so we can't use high-dose INH or ethionamide, and then other drugs need to be added. Or obviously any of your patients that might be pre-XDR or XDR is going to need tailor-made drugs. And for those, there's a system of how they choose those medicines, which you don't have to know in detail. But basically, we want to make sure that they have a regimen with at least 5 effective TB medicines during the intensive phase. And this needs to include 4 core second-line TB medications. So they will look at one from Group A, again, our moxifloxacin, levofloxacin. They would look if they can take one from Group B. Quite often, they'll have to use capreomycin if kanamycin is no longer available. At least 2 from Group C, and then bringing in some from D2 and D3 to bring a total to 5 drugs. If they can't get 5 active drugs out of that group, they can even try and add some high-dose INH or ethambutol to try and strengthen it further. But this is very much falling under the Centers of Excellence. If you look at our algorithm, this means that when we get our DRTB reflex back and we find that there's either the double mutation or there's resistance to our injectables, or there's resistance to our fluoroquinolones. Remember, we're now talking about definitions for pre-XDR and XDR. They're going to be referred for a modified regimen and going to be treated for a much longer period of time. An important decision in DRTB is at which point then do we move our patient from their intensive phase to continuation phase. And this is a very important question because the initiation phase includes this kanamycin, and the injectable is one of the biggest barriers to DRTB treatment, both because you have to go in every day to have the injection done, but it's also painful and the most toxic. And this is new in the world of DRTB, that the duration of your treatment is going to be determined by your smear, not your culture. I'm going to repeat that. It's the smear that's going to determine the duration of your regimen, not the culture. The culture is still very important, and we're still sending cultures every month, but your culture is going to be determining the treatment outcome. So what does that mean? It means that we're doing smears every month, and the smear is going to tell you whether you can change to continuation phase or not. If your smear is negative at 4 months, you can stop intensive phase and you can move on to continuation. If the smear is positive at 4 months, then you're going to have to refer and continue the intensive phase for another month. And at this point, you're going to repeat your DRTB reflex test and you're going to request a DST to specifically look at all those second-line drugs. If the smear is still positive at 6 months, we have to now give up on being able to complete the shorter regimen, the 9 to 12-month regimen. And this patient is going to have to go on to the new and extended regimen. So they will continue the intensive phase for another 2 months, and by which time they've hopefully converted, and then we'll go on to that 12 months of continuation phase. Let's look at what that looks like on this lovely algorithm, also from Johns Hopkins. You can see at the top there's somebody who was smear negative at the beginning and smear negative throughout. We see that especially in our extrapulmonary TB patients. Smear negative at 4 months is all we need to know to be able to move on to continuation phase in month 5, and that patient will be completing in month 9. Here is a more complicated scenario where the patient was smear positive at the beginning. You can see smear positive month 2, month 3, but then finally in month 4 is a smear negative result. And that one smear negative result qualifies the patient for moving on to continuation phase. This is always a little bit of a step for those of us who's been in the DRTB world for a long time, being so used to having to have consecutive culture conversion. But your patients who are smear positive and only become smear negative in month 5 or month 6, you may have to wait to therefore change them onto continuation phase. And you can see in both those patients, they ended up being on longer regimens as a result, because the continuation phase will stay at 5 months. And then lastly, your patient who still has not converted by the end of month 6, those patients are going to need a different or new regimen. We need to figure out what's going on, and you'll be referring those to an expert. The standard regimens are great for our fairly standard presentations, but there are special populations which makes it more complicated in terms of making a decision. The special population I want to spend the most time on is that of children, and where are we with them with a 9 to 12-month regimen. The WHO guidelines of 2016 recommends that children be given the same consideration for short regimen as adults. But children were not in the actual studies that were done, and so there's still a lot of experts that have differing opinions on the use of the short regimen in children. The recommendations for children are therefore mostly identical in these guidelines, and almost all of the DRTB drugs that we're using in adults are also available for use in children. The big exceptions are bedaquiline and delamide, and so the children don't qualify for that short 9-month bedaquiline regimen. Drug dosages must obviously be based on the weight of the child and be adapted as the child grows older. Let's look, though, at a few considerations that makes things a little bit more complicated. Firstly, in mild disease with children, one can actually decide to not use the injectables. There is a bit of a risk-benefit ratio one can weigh up against. And sometimes children are literally only presenting with, for example, mild lymphadenopathy. It has been shown, though, that the fluoroquinolones are important in that regimen, and that benefits of that do outweigh the risks. Certainly, if you're going to adapt the regimen, it must be done through a specialist at a center of excellence. We're a little bit nervous about using ethambutol in children due to optic neuritis and children not being able to report visual disturbances very early. The risk is relatively low, is dosage dependent, and is also dependent on the amount of time that we're going to use it. We also need to be aware of the use of moxifloxacin in children. In general, we don't like using moxifloxacin in children under the years of 8. We would choose levofloxacin in those scenarios. The biggest reason has to do with the actual preparation. So moxifloxacin comes in a tablet that cannot easily be broken. It's enterically coated, so if you do start breaking it, it becomes a problem with dosing and getting the correct dosing into the bloodstream. So moxifloxacin is not recommended in younger children. And then clofazimine is a challenge. We don't have any children's syrups at the moment, and the smallest tablet available is 50 milligrams and also cannot be broken. So you'll notice on the children chart, they're giving the clofazimine as the standard 50 milligram dose. And there's a very specific children dosing chart for all the drugs on this short regimen. There's other special populations we're not going to be discussing in this presentation. Very important that you do not initiate these patients unless you've spoken to an expert. That includes our pregnant patients, patients with diabetes, patients who've already got renal insufficiency, patients who've already got seizures, and psychiatric conditions. So in summary, the duration of our injectable phase is no longer guided by TB culture conversion. Nobody should receive more than 8 months of injectables. Our duration of treatment is either the 9 to 12 months or 18 to 20 months, and only in some exceptions might people need longer modified regimens. Clofazimine has replaced taurusidone, and patients on the short MDR regimen who will develop hearing impairment can be given bedaquiline for 6 months and remain on that short regimen. Thank you. Please do see our other modules in the series on the definition and diagnosis of DRTB, the baseline investigations, and DRTB and ARVs.